Now, some of the developers of these risk adjustment systems, if you said that's what you're doing, they would say, well, no, we haven't. But in reading through the papers, that's the impression that one's left with, that that's essentially what is being done, although oftentimes this anticipation of magnitude and direction is done sort of implicitly. So I'll try to flesh this out. I'll provide some examples. So the diagnostic cost group's hierarchical condition category system takes the diagnostic groups. If you remember, there were 118 condition categories. So each of the ICD-9 codes has been mapped to one of these 118 condition categories. And then arranges those diagnostic groups into a hierarchical structure. And then assumes that the effect on cost, certain lower order groups, for example, primary cancer, are null in the presence of certain higher order groups. So in the case of primary cancer, it might be metastatic cancer. So if a person has a diagnosis corresponding to a primary cancer, and they also have a diagnosis corresponding to a metastatic evolution or of that cancer, then, and those are in separate diagnostic groups, then in some sense only the metastatic will be counted. Now, of course, the complexity of developing such a hierarchical system is enormous, because obviously there are many different combinations. As we said, millions, billions of different combinations that one could potentially consider. And so in this approach, a cost prediction for an individual patient is based on the main effects of selected higher order diagnostic groups only. So the lower order groups for a particular patient are regarded as having essentially no effect on cost. Another example are the adjusted clinical groups and clinical risk group systems, which use essentially the same basic approach, and that is to take every conceivable combination of diagnostic groups and map them to one of a set of mutually exclusive risk categories, which are sometimes referred to as risk cells. And then basically the cost prediction for an individual patient is the expected cost for the risk category to which they are assigned based on their combination of diagnostic groups. Now, of course, the implication of this is that a single risk category can represent millions of different combinations of diagnostic groups. Just getting a little bit dry. So the limitations of these models are that the core assumptions, as I've tried to suggest, are difficult to verify. Some of the assumptions are almost implicit, because obviously there's millions and billions of different diagnostic group combinations to consider. They're inflexible, and it's not clear how well they apply to new populations, different than the ones that the physicians and health services researchers who develop them imagined. For example, one of the groups who developed one of these systems came to me and said they were having trouble getting this system to work in Germany because their physicians tended to use different codes for the same condition. In other words, the same condition in one country and another might be, physicians' habit might be to label that or code that somewhat differently. The creation of these models can be very costly. Requires extensive clinical expertise to basically sort all of these diagnoses, or all of these, diagnostic combinations. And I think ultimately these sorts of approaches likely misrepresent what is really a complex, unknowable system. And this diagram attempts to draw a contrast between that actual system and the deterministic modeling approaches and an algorithmic, what I'm going to refer to as an algorithmic modeling approach, And it's inspired by a paper by Leo Bryman called something like the Statistical Modeling of Two Cultures. And so basically at the top, one could see, well, I think you can see at the top that diagnostic groups and demographic variables are inputs to an actual system that involves complicated interacting processes, multiple diseases, multiple types of services that are available, patient and physician choices and preferences, and out the other side comes a cost of care. And the workings inside this black box, if you will, I think are really unknowable. The deterministic modeling approaches that I described, in a sense, really attempt to figure out what's going on inside that box. And I'm not sure that that's really, really a very wise approach. The red bidirectional arrows indicate that there's a feedback process going on, and the black unidirectional arrows indicate a deterministic process. And so what's shown here is that with these deterministic modeling approaches, you start with diagnostic groups. The deterministic model is sort of derived by a one-way process. It's fixed. If one purchases or leases one of these proprietary systems, essentially the arrow from diagnostic groups to deterministic model is fixed by the developer, for maybe revised annually or something. And the outputs of that deterministic model become inputs typically for a linear model, a simple linear regression. And so the idea is that you essentially have main effects, if you will, coming out of that deterministic model. The risk categories of the ACG and the CRG systems, or the selected hierarchical, selected high-order diagnostic groups coming out of the other system. And so really the only modeling or feedback occurs between, really in the fitting of the linear model to predict costs, and that's this, the double-headed red arrow, to predict cost in a new population, if you will. On the other hand, an algorithmic modeling approach, essentially it is using information about cost in a new population to decide which diagnostic groups and demographic variables are informative for that population, what combinations are informative, what interactions are informative, and so forth. So there's this full bidirectional feedback from cost of care back through the model to the diagnostic groups and back the other direction. So I'm hoping that Dr. Friedman will. Is this for me? Oh. I'm hoping that Dr. Friedman will forgive me for referring to this as regression tree boosting. I think in papers it's referred to as stochastic gradient boosting, or the term I like is greedy function approximation, particularly, or MART, multiple additive regression trees. But I found that calling it regression tree boosting facilitates describing this process to health services researchers. And essentially, this can be implemented with Dr. Friedman's algorithms, which is what I did in SAS, or using TreeNet with tree-type regression. And so essentially, the example that I'm going to work, what I'm going to describe, you can take that as TreeNet with tree-type equal regression, but in fact, I didn't open up the TreeNet software, so I didn't determine exactly. In other words, it's based on the Friedman algorithms, but I don't want to make assumptions about precisely how it works.